All right, so thank you very much for the invitation to participate in this core program. My goal here is to introduce a tool that, if you believe me, will make you a much better orthopedic clinician. It's going to be the most valuable tool you have outside of the operating room. It's the only tool we can use in our office that gives us real-time dynamic imaging of soft tissues. And in a lot of instances, we can eliminate the need for MRI scan depending on the clinical situation. So I'm going to introduce this weapon or a tool by talking about 7 common ultrasound-guided orthobiologic injections. I know the curriculum says 10. Really, to do this some justice, I'm going to go through the top 7. These are all the different things, and this isn't even a complete list, but these are all the different things where ultrasound can definitely play a role in making the diagnosis or in guiding procedures. And now these are the 7 we're going to focus on in the next 12 minutes or so. In the knee, we're going to talk about intra-articular injections. We'll talk about how to use ultrasound to do an intra-articular hip injection. There's a lot of uses around the shoulder, so we'll spend a little bit more time around the shoulder looking at intra-articular injections, subacromial injections, biceps tendon sheath, and supraspinatus tendon injections. And then, of course, I can't be in a webinar with Alan Mishra and not talk about elbow injections, but Alan's going to cover that as well. So, I came out of residency back in 1998, and at no point in that 5-year program did they ever say, okay, now that we're ready to go, everybody cover your eyes and let's do the injection, or everybody cover your eyes and let's do the surgery. And this is really the same thought process here. Anytime you can see something better, whether it's an arthroscope or a microscope or an ultrasound transducer, it will make you better. And essentially every paper that's ever looked at this question has found that ultrasound makes a good clinician a great clinician. It can make an average anatomist or clinician a good one, because you can now see underneath the skin. You don't have to close your eyes. You don't have to guess. So let's jump into knee. Now, I know a lot of you will say, I know how to do knee injections. I can do a parapatellar knee injection. I never miss. And I'm here to tell you that we all miss. We all miss about 10 to 15% of the time. And if you think back to that last knee injection you had where the patient said, God, that one hurt a little bit, or they call you back, or they come back to clinic in a month and they say, yeah, that last injection just didn't really do the same as the other one. That's probably the one where you got into the fat pad, or you didn't get all the way into the joint, or you got into some other intra-articular soft tissues. So I'm going to spend a little bit of time looking at how we use ultrasound to 100% of the time get that needle into the joint. Now, these are some of the other indications that we aren't going to cover, but just to give you an idea of the breadth of applications for ultrasound, we can do MCL, meniscus, patellar and quad tendons as well. The most common way that we inject the knee joint using ultrasound guidance is this suprapatellar lateral approach. And the reason is we can see the needle. In the example on the video, it's coming in from the right side of the screen. The needle is that bright white or hyperechoic structure. And the reason why this is the preferred approach, or the most common approach, is because we can see the needle all the way from the skin, all the way into the suprapatellar recess. We can see the needle underneath the quad tendon, and as we inject, we can watch the injectate expand, and we know that that's connected obviously with the entire joint. So this becomes a very quick injection. It becomes an injection that you can accurately place into the joint 100% of the time. Remember, there's no radiation, there's no time pressure, there's no need for a scout image. You're just doing this in the office.
Hi.
Hip injections. So no longer do you have to send someone to radiology or go to a procedure room to use fluoro to do an intra-articular hip injection. It is an injection that ultrasound makes just a piece of cake. And again, to be complete, these are some of the other applications around it.
Two of your properties, Kelly Lynn and Venus, do you have maybe houses there?
Is she in San Antonio?
I didn't ask.
Yeah,
Should
she
I
used
say
to.
Kelly Lynn or in Venus? Is Venus close to San Antonio?
What did you just say?
Kelly Lynn is the street. Venus, I think, is the city. Is Venus around San Antonio?
No, I don't have any properties. I have a property on Cassiopeia and a property on Shady Oaks.
Okay, that was.
But they both have property managers, and so
Let me ask her more.
just put her on speaker.
Hi. Oh, it hung up on her.
What did that
Gateway. As usual. We
Put
should put
a
it.
sign. I'm
I was
putting a
gonna
sign.
say we should also put a sign that says Gateway that
Yeah,
way.
that way. Like,
Oh, he's back. Rocky is back.
who?
Rocky.
Is that what we're calling him?
Yeah, the Mexican Rocky. Did you just hear the music when he
Wait, so that's not our usual guy?
No, it is. He
Oh.
just got a hoodie on.
Oh.
He's Mexican? I thought
He's
he's
the
a white guy.
No, he looks. I got close over there.
Oh, right, because he saw him.
I'm gonna order salad from Salada. Trying not to be that guy. Do you guys want anything from that?
Yeah, I'm trying to look good too. I'm 10 pounds.
Obviously, landmark guided hip joint injections, those aren't guaranteed to always be intra-articular. Here's a way
Working on squats.
transducer in your hand.
Dr. Buford, since you're a lot older, but I feel like you have more energy, what do you do? Do you like take supplements and stuff?
I'm trying to unpack. I'm trying to unpack if that was an insult or not.
No,
Bitch, what?
What?
Hold on. Dr. Buford.
Okay, Daddy, come on. Okay.
Say, wait, what?
Towards the elbow.
What do you do
Remember
to have
that
so
the
much
common
energy?
extensor
You work
tendon
out, like,
is
you
more
take supplements?
superficial
I work out every day.
than the radiocollateral ligament as you look at the joint here.
But that's
And
just
so
what I'm
if
built.
somebody
I don't
has
sleep
more
much. I sleep
damage
5 or 6
or
hours
more
a day.
destruction
I'm up
or
at 5
more
a.m.
distorted anatomy
every
closer
day.
to the
Yeah.
joint, you know
His
that
knee
their
slowed me down
ligament
a
is
little
more
bit, 'cause I
likely
normally
involved
play
than
tennis
just the
every
common
morning.
extensor
I used
tendon.
to play tennis every morning from 6 to 7.
Here's an example of a supine patient.
So I've been
This is an
here on
in-plane
driving
injection. This is
operations.
actually one of those
I've been
handheld
playing
transducers, and the imaging has gotten even better than what this was years back. So even with a small
Wow.
handheld transducer, you can see that we can guide this injection right off of the cortical margin,
No, I don't
right at
do.
the
There's no
epicondyle.
supplement that would do it.
As I inject in this example, you can even see
Yeah.
that some of the anatomy is lifting away from the epicondyle, which
Do you
indicates
check
there's a
your
bit
labs?
more
You go see
damage
someone once a
to
year?
the radiocollateral
Yeah, I mean,
ligament,
How old are you
even the
again?
common
I'm
extensor.
30, but
Then
I'm
it
an
might show
anemic.
up
I
in a
went to
simple
go get my
static
last
MRI
one, I
image.
need that.
You should be on a multivitamin any day, anyways,
Shoulder
that has iron in
injections.
it. Like all the women, once a day.
I
plus
prefer to
iron.
inject in the lateral decubitus position, but as I mentioned before, there's lots of ways to inject in all the different structures. I operate in the lateral decubitus position, so this is a very natural way for me to transition to doing ultrasound guided injections in the office. In this little schematic, the transducer is basically over the posterior arthroscopy portal. And this is one example of how to do this injection from lateral to medial. And the purple arrow is the illustration of the needle path. The intra-articular portion is that going to be right at the tip of the white needle. Now, first we're injecting a little bit through the infraspinatus muscle because we're going to be doing a bit of a longer injection here. I think this was a hydrodilation clinical case, so we know we're going to be injecting a bit more volume, so we're injecting a little bit of lidocaine and marcaine. And then we take that needle through the infraspinatus into the posterior aspect of the glenohumeral joint, and here you can see us inject. So again, it's a way to be sure exactly where the tip of the needle is from the moment you first make the decision to go ahead and inject. Now the biceps tendon sheath, I'll just show you 2 quick ways to inject. There's either long axis, which would be on the left, or there's short axis. And to use terminology that orthopedists are more familiar with, this would be a sagittal view versus an axial view of the biceps tendon. Now in this long axis view, the needle path, you can come from proximal to distal or distal to proximal. Here's an example here. The needle is always going to be a bright white line when we're in plane. See if we can get this to run. There we go. And as we inject, you can see the fluid basically lift off the sheath, and it really is like taking a highlighter to the tendon. It's really starting to show exactly where the tendon is as we inject into that tendon sheath.
He's insane.
Very similar concept. This is just a short axis or
So
axial
you're talking about
approach.
him, the
Needles
one
coming
with
in
the
from
dogs and
lateral
those
to
dogs?
medial.
Same guy. Yeah, he lives on the first floor right across.
And as
from
we
the
inject the
ballpark.
sheath here,
So,
you can't really track
he's not
proximal
doing the
distal
same-
because we're out
he's
of
so
plane for
insane.
that.
He's not even
But you
doing
can
the same
certainly
thing every day.
see
It's
kind of
almost like
the
he's got
circular
a plan.
biceps tendon sheath enlarge as you inject. Subacromial bursa and rotator cuff injections, you can do these either seated or lateral decubitus. There's really not a specific advantage other than I think lateral decubitus is a bit more ergonomic for the doctor. So selfishly, I prefer lateral decubitus. The other advantage there is the patient's already laying on the bed, so that 1 in a million patient that may go vasovagal, they're protected and they're safe because they're already laying on a table. The technique is really the same. You can do this in what would be the sagittal image or coronal plane, depending on how you orient your transducer. And here's an example of doing it with what would be called a coronal image on an MRI scan, or a long axis image if you're a sonographer. So the needle's coming in from left to right. As we inject in that plane between the superior border of the supraspinatus and below the deltoid, you can see that black fluid start to expand and track medial and lateral. Here's an example doing this in what would be a sagittal plane or a short axis view. And as we inject, again, the tip of the needle is that white line. You can see the fluid track both medial and lateral. That lets us know we're in the right plane. Now, for ultrasound guided injections for cuff tendinopathy, this is something that's near and dear to my heart as a shoulder surgeon. We've come across a protocol or landed on a protocol that's been very effective. We're about to publish 7.5-year results with different inject dates, where we inject 3 different things to get maximal response. We inject the glenohumeral joint. Thought process behind that is, remember, a lot of these partial tears start on the articular side. And some of these older patients may even have some degenerative changes in the joint. For whatever reason, injecting into the glenohumeral joint gives us those 2 advantages. We put a little bit intratendinous. Typically, we're talking about the supraspinatus tendon, and we put some in the subacromial space. So here's an example where the needle's actually going into the tendon, and as we inject, again, this is 1 or 2 cc's, it really illustrates that supraspinatus in the middle of the screen is partially torn. If that tendon wasn't torn, you wouldn't see the fluid flowing there, and you wouldn't see the tendon kind of expand. And so that's just one component of how we treat somebody with symptomatic cuff tendinopathy.
I need to know what y'all want.
So I'm hoping to challenge your boundaries. These are all examples that will give you kind of evidence that these patients can benefit from these procedures. And it's not just come back and see me when you're ready for surgery. We can help so many more patients that are in this treatment gap between pain and a clear surgical indication. We can help them by using these orthobiologic approaches, which really require ultrasound guidance. And so just keep your eyes and ears open, keep your mind open. If you want to connect with me, I'm available on LinkedIn and YouTube. It's Dr. Don Buford on either platform. So thank you very much.
All right, thanks very much, Dr. Buford. That was a fantastic overview of your uses for ultrasound in your practice. A couple questions for you. First of all, are there any injections that you're doing without ultrasound? Are there some where it's nice to have versus you need to have it?
At this point, I use ultrasound essentially all of the time. Okay, now you could always create some sort of clinical situation where you may run into a room and not use it, but I've got ultrasound in every room at this point. So sure. I just can't think of a reason where I wouldn't want to be 100% certain. I'm in Dallas, so there's going to be people where if I don't have ultrasound, it's actually coin toss, because I can't feel any bony landmarks. And so all of us come across those patients. And so having ultrasound in the office, I think is really, it should be a required thing for an orthopedic surgeon or for an orthopedic clinician in general to have ultrasound, because there's things that we do where you just don't want to guess. And if there's a way to not guess, we should take advantage of that.
Maybe.
Sure. And to what extent would you say you use ultrasound versus for injections versus for diagnostic purposes? Is it 50-50? Is it more one than the other?
Yeah, it's a great question. Just from experience with training a lot of docs, multidisciplinary docs, you know, kind of the gateway is to use it for injections.
What's that?
That's kind of the gateway, because people will make their own diagnostic decisions, and that's a bit more nuanced and takes a bit more reps, as Dr. Lawley said, and a bit more practice. But doing the injections, you know, if you've already made the diagnosis and they've got biceps tenosynovitis, then you can put the transducer there and you know the anatomy, and this is applied anatomy, and you can do that injection. So most people, as they get more and more comfortable doing injections, now they can get more and more into looking at pathology. Full thickness tendon tears, not very hard. Probably nobody's going to miss that even from day 1 or 2. It's the partial tears and some of the more subtle things like the tenosynovitis, and there's a great illustration again, and Dr. Lawley's talked about that around the Achilles. Those sorts of things take a little bit of training, a little bit of practice. But I would say everyone that hasn't started to use the modality, just start simply. Just start doing some of your top injections.
Sure. And then lastly, I don't think we can talk anything in healthcare without getting to the economics a little bit. So any thoughts on the financial sustainability of having ultrasound in your practice, and any coding implications for doing an injection under ultrasound versus not?
So that's it, man. There's so much to unpack there. That's a great question. And the key is, at the end of it all, at the end of that whole discussion, it is still not going to cost us any money to use ultrasound. Okay, I just gave the talk last weekend in a course that we've had now for 17 years. When I first gave the coding and reimbursement talk, the average reimbursement for diagnostics or injection-guided procedures, if you sum all that up, was about $130 per use. That number is now down to about $70. But even at $70 with an average machine, and the average machines now are more than adequate, you're going to have to use the machine about 12 times a month to break even. Okay? So that's not too high of a bar, 3 times a week. Okay, so if any of the clinicians that come to our course, we tell them, if you look at your last week's clinic and you wouldn't have used it 3 times in any combination of injections or diagnostic, then maybe it's not for you if you're not that busy. But essentially any orthopedist that's open for business can probably use it 3 times a week. And at that point, you're going to cover your lease. Anything more than that, you can buy your yacht.
All right, great. I'll open up to the rest of the group. Any questions? Otherwise, we'll go on to Dr. Mishra here.